My name's James. I'm a radiation therapist from here at Paediatric in Parkville. And I'm going to talk today about a really interesting case, both clinically and in the use of SGRT, where we treated a very young patient for total body electron irradiation. I'll also give a little bit of an overview of paediatric SGRT in general here at Paediatric. We've found that SGRT can be a really powerful tool for paediatric patients, so I'll just highlight some of the indications and typical uses for us here, and then I'll go into a little bit more detail about the case study. So we typically treat 70 to 100 or so paediatric patients each year. And obviously paediatrics is defined by patients under 18, but we do treat all the way down to a couple of weeks, even a couple of days old in some cases. You can see here that most paediatric treatment sites that we treat here at Paediatric are brain and head and neck. And in these cases, Align RT has really allowed us to utilise the open face masks and improve patient comfort for this cohort. But we do also treat a number of other sites as well that you can see. Now, I've done a little bit of research, and anyone that was here last year may have seen some of this. My colleague Kenton presented some of this on my behalf, but we've done a little bit of research looking into the treatment data for our paediatric patients with SGRT. And just for the sake of a simple analysis, I've just broken down the patient numbers into stabilisation requirements. So that is mask or non-mask, and also craniospinal or CSI irradiation, because this is quite a unique setup and quite a unique treatment workflow as well. So looking at each of these groups, and I understand that this slide is a little bit busy, but you can see in the columns highlighted with the green colour that setup time, IGRT time, and total time have all been reduced with SGRT by a varying degree across the groups. We believe that the slight increase in treatment time that you can see here may have been due to the beam interruptions that we were seeing and the consequential holding of the beam as the patients moved, but it's hard to tell from this data alone, and we do need to dig a little bit deeper into this eventually. Interestingly though, our CSI treatment times have reduced quite a lot since introducing Align RT, which has been really great for the patients and also us, because these can really feel like a marathon at times, taking sometimes well over an hour. We've also seen improvements to setup accuracy. So again here, focusing on our CSI patients, we've reduced the average number of KV images taken over the whole course of a treatment by reducing setup errors that would have otherwise required repeat imaging. So this reduces time, it reduces dose to the patient, and it's obviously a more accurate treatment is a better treatment. So moving on to the case study now, and I will just warn you that some parts of this are a little bit confronting just due to the patient's really young age, especially if you aren't used to working with paediatric patients. So this case was a 4-month-old presenting with relapsed leukemia to the skin, and they had several cutaneous deposits as well. They were prescribed TBE to 15 Gray in 10 fractions. Obviously, because of their age, general anaesthetic was required for the treatment. We also planned a photon skin plan as well to boost the lateral edges of the patient where we didn't think electrons would be able to penetrate deeply enough. And we did a 9 Gray boost in 9 fractions as well to the cutaneous disease sites. So for conventional TBE here at Paediatric, the patient stands on a rotating platform in front of the gantry. There's a 300 centimetre SSD with the gantry head at 270 degrees. During the treatment, the platform rotates at a speed that is calibrated for the dose rate of the treatment field that ensures an even dose to all exposed parts of the skin. Areas like the axillas, the feet, palms of the hands, the inner thighs, these are then boosted with the small electron fields as they typically don't get enough exposure from the TBE. So obviously, this case, this technique wasn't possible for the patient that's very young, also under GA. So we did have to get a little bit creative. So the patient was positioned like this, supine, arms slightly akimbo, legs frog-legged, and there was a vac bag under the entire patient to locate the limbs. Since we didn't use a mask, the vac bag really helped locate the head as well. Now, to lull us into a false sense of security, we started with the easier bit first, and we treated the cutaneous boost sites with the conventional electron treatment. Obviously, positioning the entire body for these sites is less crucial, but AlignRT was used to accurately position each site one at a time, and then confirming the field light and SSD measurements. We then moved on to the TBE component. So due to the field size limitations, we had to have a superior, mid, and inferior junctional fields for the anterior side and the posterior side. We had 0.8 centimetres of perspex constructed as a table to cover the patient for the anterior fields, which provided a bolus effect. For the posterior fields, the couch top and the vac bag provided enough of a bolusing effect that we didn't obviously need the table here. For this treatment, obviously, positioning the entire patient was really crucial to ensure these different junctions were maintained accurately and that all parts of the body were well within the fields. For the rind boost component of the TBE, which was treated with photons, we had several fields along the lateral aspects of the patient to get dose into these areas where we thought the electrons wouldn't reach. And again, this required really precise positioning, particularly at the head, to ensure that we treated accurately. Didn't want any extra brain dose. Imaging was not really possible, given the potential collision issues with all the extra equipment, but also difficulties just visualising soft tissue that we were going to be treating. So we really relied here on AlignRT. Although, having said that, we did confirm the head position with KVs just to be sure as well. As this was a new technique, we wanted to do a mock-up to confirm the plan before the patient came in. And again, a little content warning here, as this bit's actually almost a little bit creepy, but we 3D printed the patient to use for a mock-up. By doing this, we had an exact one-to-one replica of the patient, and we could put this in the vac bag. That meant we could ensure our planned SSDs. We could ensure that the patient would be well within AlignRT's field of view. We could ensure any collision risks, and that the perspex table would appropriately cover the patient. And it also meant we could just go through the workflow steps and make sure that this was going to work as smoothly as possible. And this is actually how we did some of those initial measurements to confirm the build-up effect from the vac bag and the couch as well by using this, this little mock-up. For the treatments, we used AlignRT for setup only, treat without beam control. TrueBeam doesn't like beam control on electron fields, but we were pretty confident the patient wasn't going to move anyway under the GA. We had ROIs for each region that we were treating, which we used for the initial setup and then also for passive monitoring during the treatment. But again, we were very reliant on postural video to position the patient here. So these are just a couple of examples of the ROIs we used for the inner thighs and the pelvis, and also the abdomen and chest. And in this case, we also had the chest and a little ROI on the head as well, just to ensure that the head didn't move at all during that superior anterior total TBE electron field. I wish I had some examples of postural video and how good that was to position the entire patient, but we were a little bit reluctant to take too many screenshots of the live view just for the dignity of the patient. This shot, though, does provide a little bit of context to the setup. So it shows the perspex table in place here for the superior field. We did uncover the patient's beanie for the treatment. Obviously, this is necessary for electrons. But we cover them whenever possible when they're under GA so they don't lose too much body heat. And this actually did create a little bit of a challenge for us as well, making sure we could position them accurately, but not take too much time with them uncovered. We did lots and lots of TRD measurements at many different points. Some of the physicists in the room might have a little bit of PTSD from some of that. Because it was such a non-standard technique, we just wanted to verify that everything was as planned. And it was as planned within most areas except where we'd been doing the photon rind boosts. So it turns out Eclipse actually didn't model the electrons very accurately here, so we were able to get enough dose in these areas from the TBE alone, and we could omit this part of the treatment. The boost treatments took about an hour altogether, and this was just due to there being 7 different sites that we had to set up independently. The TBE treatments started off quite long at almost 1.5 hours, but we did get them down to around 40 minutes once we got comfortable with the setup and the workflow. And the patient did have a really good response to this treatment as well, which was really nice to hear. So overall, I just wanted to highlight how useful SGRT was for this patient. Without it, we wouldn't have been able to confidently position them to at least the same level of accuracy that we needed for this particular plan. Measurements, tracings, photos are good to a degree, but they're time-consuming and they can only go so far in providing that accuracy of setup. So seeing the patient's position in real time compared to their plan position really helped us deliver this treatment. I also just wanted to highlight how SGRT can be used in ways that we don't necessarily expect. It's important for departments to communicate its capabilities to the department, but also to the wider MDT, so that cases like this that could have been dismissed as not possible before even getting to us can be explored so that we can offer the patients the best possible care.